Welcome to today's webinar, Curing Payment Confusion Through Industry Collaboration. This is Ashley Myers, HFMA's Client Services Specialist, and I will be moderating today's session. Now it is my pleasure to welcome today's speakers. Seth Cohen is the president of Cedar and a healthcare technology leader who co-founded UDA Health, which was acquired by Cedar in 2021. He has held leadership roles at Castlight and began his career as a healthcare consultant at McKinsey & Company. Brad Dennison is Director of Editorial and Policy Affairs at HFMA, where he leads the association's award-winning editorial team overseeing HFM Magazine, white papers, e-newsletters, podcasts, and social media. A 25-year news media veteran and former senior VP at Gannett Inc., he has driven content transformation while earning 65 national and regional awards since 2020. Sachin Jain, MD, MBA, is CEO of Scan Group and Scan Health Plan, serving 300,000 Medicare Advantage members across 5 states. A Harvard-educated physician and healthcare leader, he previously served as president and CEO of CareMore and Aspire Health. He's held key roles at CMS, CMMI, and Merck, and is an adjunct professor at Stanford and board member for AHIP, Omada Health, and others. And with that, Seth, I'll turn this presentation over to you.
Great. Thanks so much, Ashley, and thank you so much for joining us today. I'm delighted to be here with Brad and my good friend Sachin to talk about a topic that comes up in just about every conversation we have today. You know, one thing that I feel very privileged in, and as Ashley gave a little bit of my background, is I've had the opportunity to work with employers, I've had the opportunity to work with payers, and I've had the opportunity now currently to work with providers. And Sachin also has bridged that. I'll let him speak more to that too. So I do feel like I have a vantage point to think about some of the things we're going to talk about today, and to really dig into, you know, how do we kind of look at, you know, curing payment confusion through superior industry collaboration. And from our own individual perspective, as well as our joint collaboration with HFMA, which we're going to get to a little bit more shortly, the vast majority of healthcare finance leaders, in other words, all of you, believe that payer-provider relations are more strained more than ever, and they're really a hindrance to optimal care. And so we're going to dig into this a bit more of like, well, how did we get here? How did we end up confusing and sometimes even harming the very patients we're trying to heal by sticking them in the middle of a lot of this payer-provider friction? And what do we do about it? So I thought what we could do is we could start by examining some recent changes to the affordability landscape. But to kick things off, and we want to make sure that folks are able to get the education credits that are in part bringing you here, we want to leave some time for a poll. And the question here for our first poll is, what percentage of patients find reconciling a billing issue between their payer and provider to be stressful? So what are patients saying? And I can just tell you anecdotally, when I tell folks what I do for a living, every time I mention my line of work, someone comes forward with a story of, oh, you won't believe, you know, what happened to me here or here. Brad, I know you were also reflecting on a recent billing experience of your own, right?
Yeah, we're all patients, right? And we're all experiencing the healthcare system. And I'm not sure that I've received a bill in the past year that I haven't had to make calls on. So 100% of the people in my household have had issues and find it stressful.
Yeah.
Yeah.
Yeah. Yeah. And sure enough here, it is about 71%, which I guess, at least to me and Brad, feel low. But also, you know, we're sort of jaded by these data points, but like, let's just take a moment to pause and just reflect on that. The vast majority of patients accessing healthcare find billing to be a stressor, right? Our job, our mission is to help heal patients. And what most people are saying is this is the feeling they have at the end of their care event. So let's like not lose sight of the magnitude of that. But let's move on too, because we have more to cover here. For our next polling question, according to a recent CMS report, how much did US healthcare spending increase to in 2023? And as we were just chatting, as people are putting in their guess, I'll give you a note of context that we recently shared as a team here. And Sachin, you might appreciate, I don't know if you know this one, is that in 1961, US President Nixon stood before Congress and declared that we are in a crisis moment in healthcare. Our costs are out of control. And if we don't do anything immediately, we're going to be beyond repair, that we're in a really irreparable. He tried to really drive urgency. That was in 1961. In 1961, our US healthcare expense was 2% of GDP. And I believe now it's about 15 or 16%. So since he made that comment, we've sort of kind of quintupled it. See the polling results stick in?
It's a federal jobs program, right? I mean, we have to have full employment.
At least up until now. We'll see what happens to this administration. The answer is C here. It is 4.9 trillion. Yeah, this federal jobs program is getting to 5 trillion, about 15 to 16% of our GDP. So this is an important backdrop for what we're going to be talking about because these unsustainable increases in costs are moving into the patient realm. But for our last polling question for now, what percentage of privately insured Americans are on high deductible health plans? Let's guess here. And actually, as a note of context here, I can share back in 2007, that answer was 5%. So
So what's the definition of high deductible? Do we have
Great question. Yes, there is a federal definition. Like you have to legally pass a certain. I don't know if I think it's $3,000 or maybe it's $2,500 individual and maybe $4,000. Don't quote me exactly those numbers, but you have to have a very specific deductible level in order to qualify, as in be eligible for an HSA. That's a federal mandate. Oh, thank you. We just got there. That's actually much higher than I thought. $4,000 individual. So that is the definition. So back in 2007, I know it was 5% of plans. So the answer just came through. It seems like most people think it's 40%. And the answer, very close, is D, 42%. Technically 41.7%. So if you think about it, so that's sort of an important point to land on. We're going to talk more about it, is that that's been a pretty significant increase. So with those polling questions out of the way, thank you. This is for us kind of an important backdrop to our conversation here, which is we sort of are all we all know / are overwhelmed by / fatigued by the fact that healthcare costs have just been growing and growing and growing. It's this kind of like it just sucks up, kind of all the resources out there. And it continues to be unsustainable to the point you wonder, what does unsustainable even mean? But the thing that sometimes gets lost, and I think is really important as we think about the impact of the patient on payer-provider friction, is this. Right, so what are we looking at here? This is the increase in the out-of-pocket spend for patients since 2016. And what you're seeing is these are pretty significant increases that the patient has had to bear out of pocket, right? A lot of this is driven by the increase in high deductible plans, but it's not only high deductible plans, even non-high deductibles, as Sachin was asking, the limits of those have seen increased cost share, right? And what's also interesting when you overlay this, the type of spend that patients are paying is changing. Right. So even as out of pocket has grown, the amount of dollars paid via a co-insurance, actually, that's I should have caught that. That's not the right label. It's copay, not co-insurance. The amount paid via copay has gone down, and the amount paid via deductible has exploded. Right. So excuse that label mistake, but as you think about it, copays are very different patient experiences than deductibles. A copay is something it's like a dentist appointment. You show up, you pay to the front desk, it's salient, it's done, you resolve it, you move on. A deductible is something that typically is only calculated after you leave. It involves payer adjudication, it takes a long time, and it can be a major stressor and surprise for patients and families. There's one other trend that I think is worth pointing out. And I think we find many people are surprised to see this. And I'd be curious if folks who are attending are surprised. But what you're seeing here is that not only has out-of-pocket costs gone up for the patient, and not only has deductibles gone up for patients, but the amount of dollars owed by uninsured patients has been rising significantly as well. So what this means is by October of last year, almost 50% of all dollars owed from patients, so think about it, almost half of all the dollars that patients owe are being generated by folks who have no insurance coverage at all. And that has gone up by over 15% just over year. Right, so the patient relationship now to their healthcare has changed meaningfully, not only because they're absorbing more cost share through their insurance plans, but many of them are just not accessing insurance altogether. And we're going to talk a little bit more about what all this means shortly. And so as we think about this, this for us sets the stage for some of this payer-provider friction, right? Because in a world of rising costs, what payers have clearly been doing and will continue to do is to try to cost shift, right? Because they can't absorb cost increases on their own, right? They compete for employer business and they have to compete on the basis of price. So many of these payers will say, oh, well, in order for me to keep my rate increases low, I'm going to just pass on a lot of the cost increases in the overall delivery system. I'm going to just pass that on to that patient, right? So patients either accept that through the form of a higher deductible, or as we're seeing in our data, they just opt out of the insurance world altogether, right? So some of that friction, some of that payer-provider friction, we think is very much grounded in these fundamentals of not just overall healthcare spend increases, but the patient increase as well. Okay. So how do we solve this critical industry challenge, right? How do we, every time I show up to a provider or to a payer, there's so much intense and frankly even emotional concern around how to repair these relationships. So what do we do about this? At this moment, I'm going to hand it over to our partner, Brad, here, who's going to lead us through a discussion of some key findings around the current state of payer-provider relationships, as well as some innovative solutions for collaboration.
Yeah, thank you. Thank you, Seth. And without a doubt, it's patients who are caught in the middle of this payer-provider divide. And from HFMA's perspective, and taking that friction away from the process is reason enough to work toward improved payer-provider collaboration. And so what we wanted to do today was take a look at some of our key findings from the report released in November called Bridging the Payer-Provider Divide. All right, so here's what this is. This is a survey of CFOs, more than 100 respondents in the survey. 58% of them said that payer relations have deteriorated over the past 3 years, and certainly signals a growing challenge. Probably not a huge shock to anybody on this call, but Sachin, we'll start with you. We talked about this a bit the other day. I'm intrigued. You referred to healthcare as a promiscuous industry. And so talk a little bit about what you mean by that and how does that impact payer-provider relationships?
It is the most promiscuous industry. And I say that in part for effect, but in part because it is exactly how everything works. Every health plan, contracts with every provider group. Every health plan works with every broker. And what ends up happening is the opportunity to actually engage in deep collaboration is missed because everyone's too busy meeting with everyone. And, my view of where this industry needs to go is we actually need to be selective. We actually need to stop dating and we need to get married and get married to a few partners, one, maybe two max, three's a crowd, and actually build the IT infrastructure between partners, the technology stack, the virtual, integrated experience that should exist between plans and providers. And that's where we're taking Scan Group and Scan Health Plan is as we engage with our providers, we're thinking about how do we work with a smaller group of providers in a particular geography so that and have them make similar trade-offs and work with a smaller number of plans so that we are able to invest in the shared infrastructure to be able to create a better experience for patients. The friction exists because there is really no partnership, right? There's really no partnership. How we engage with each other is annual contracting, where we're arguing mostly about rates, and then utilization management, where we're arguing about what's actually covered. There isn't a lot of work together on actually accomplishing our stated objective, which is to actually take care of the people that we're taking care of. And so I think that there needs to be a reset in the industry, and it starts with just calling it what it is, which is it's a promiscuous industry. Everyone's involved with with everyone, too many partners, and we need to actually narrow the number of partners that we work with so that we can go deeper and actually do better. That's my view of it.
Great points. Let's move on to our next data point. 87% of CFOs surveyed believe that strained relationships are hindering optimal patient care. Obviously, very concerning. And anytime we do a survey question that gets something in the neighborhood of 90%, you have to take notice of that. For both of you, Sachin and Seth, given that 87% number believe that payer-provider relationships are hindering patient care, talk a bit about your experiences in health tech and payer leadership, and how can we actually flip those relationships from adversarial to more collaborative?
Sachin, do you want to go first? Share any experience?
Yeah, I mean, look, I think we have to kind of change the entire script of the industry, and it's going to take a few bold organizations and bold health plans to do this. But I think it's getting out of the framework of utilization management and getting into a framework of, like, if most things are going to get approved, how do we get into a framework where what we're really doing is a back-end adjudication as opposed to a front-end adjudication? So we assume that, it's going to be approved, but on the other side of it, if there was actually, kind of a financial reconciliation about not approving things, that there might be an opportunity there. And I know there's a number of technology companies that are working on flipping the equation right now on how we think about utilization management, how we think about prior authorization, and how we think about the engagement between plan and provider. I also think we have to change our expectations of time frame. I mean, as a patient, when you need a test and you're waiting 2, 3, 4 weeks for your insurance company to actually approve it, it's sort of criminal and inhumane. And we actually have to call it that. And my company does a decent amount of this. So I think it's important for us to actually acknowledge our own warts. And I would say, when people on my team say, oh, we'll get back to them in 3 days or 4 days or 5 days, I'm like, would that be acceptable if it were you in a similar situation? So I think we actually have to change our expectations and do real-time adjudication where it's at all possible. And if something's going to take a while, it should be not because it's stuck in a queue. It's because we're actually waiting for more information, or because there's something that we're actually, trying to resolve or better understand about a patient's situation. But oftentimes what's happening is we're not doing today's work today. We're doing today's work in 2 weeks or 3 weeks or 4 weeks. And on the other side of that is a patient whose experience is really being negatively impacted, and where, a stage 1 cancer is actually potentially progressing to a stage 2 or a stage 3 cancer. I think provider groups have their own work to do on actually creating access for patients, to be clear. I think there's work to do on all sides, where, we've normalized abnormal things. I have a family member who recently faced a cancer diagnosis and was told that the follow-up staging MRI was going to be in 8 weeks. And had I not known the CEO of the hospital, it would have been in 8 weeks. Because I knew the CEO of the hospital, it happened in 8 days. And what I would say to you is, even that 8 days felt very long to our family. And how do we create a healthcare system where everyone gets the treatment that they get when they actually know someone, or where they have access? And I think that's the world we have to try to evolve towards.
Yeah. I feel like we all have those human stories, and I think putting that lens is so critical. I'll first share a bit of a fluffy point, so bear with me. I know this is a finance audience, so I'll get to more of the data. But I think the fluffy point is the following. I have, and Sachin's done the same. I've sat in payer meetings. I've sat in provider meetings. I've sat with all payer execs. I've sat with all provider execs. And I will assure you, each side has a very well-articulated narrative of all the ways that they are wronged. And it's substantiated with data. And it's a crisp narrative, and it's a narrative that continues to get reinforced, right? You sit with payer executives and they'll talk about the overutilization of unnecessary care. They'll talk about all the ways that providers are trying to consolidate and get bigger and take on market power and push them into tough positions, and how payers are trying to drive affordability and no one else is appreciating that. And then you can sit with providers who are talking about all the ways they're trying to drive patient care and the ways that oligopolistic payers are crowding them out, stuffing them down, So why am I bringing this up? I do think the fluffy point I'm going to make is just, a little bit of just, even if it's not empathy, just like understanding that, hey, we are all living in narratives. We have these narratives. And these narratives have a lot of truth to them. There's data and they're real. I'm not in any way suggesting otherwise, but sometimes they can be confining. Sometimes they're very good at explaining things. Sometimes they can be confining, and sometimes we presume something about the other side that may or may not be true. And a couple examples that I've reflect on and sit through is, like, I remember working with certain payers, some national ones, to bring something innovative and helpful to the provider community, truly something that providers would value. And I would get to, like, we would be driving to the meeting and I'd be so excited. I'm like, okay, but before we get to your topic, your innovation topic, Seth, we have to first talk to them about the pricing of their specialty drugs and their the buy-in, they bag it and, they add the margin to it. And we got to make sure that I'm like, you can't start a conversation around compressing margin. You can't go to the zero sum thing and then hope they're going to be super engaged on the collaborative, innovative thing. So, I mean, it's kind of recognizing that, like, we're operating in these frames and we have to sometimes, like lead with truly a collaborative point. And now on that, like, so what would that be? I mean, Sachin talked about the human side of it. I would say, for our view on the billing side, there is so much to do. Patients do not use $120 billion of HSAs that are sitting in their accounts that many times they don't. 2/3 of HSA account holders have never activated their account. If payers want to help providers and patients, payers could be collaborating and saying, hey, let me help you. Let me give you data so that when patients show up, they know to look to their HSA, or that that maybe they should access it, or maybe they could use some of those dollars, right? Like, if many patients don't know if they're eligible for Medicaid. They don't know that they don't have to pay anything. They don't know if they're eligible for ACA. They don't know that they can qualify for subsidies. These are areas where payers and providers could absolutely collaborate and bring dollars in that are not in some zero-sum dynamic between payers and providers. These are dollars that are sitting out there that can be forms of reimbursement and give relief to patients and providers. So there are some real spaces of collaboration. It's just a couple. And something else, I'll add is, when we think about what's available to patients today, right? It requires some sophistication and it requires some digging, right? You have to know what the insurance plans are that are available. You have to know that there are HSA accounts out there that are available. Pharmacy copay assistance. Over 90% of pharmacy copay dollars, like this, these are the subsidies that, like, AbbVie and Genentech and Roche make available. People don't use these. So you have to have some sophistication to find it. But the good news is that technology is our friend, right? And so, I don't want to contribute too much to the AI hype cycle, but I do think that a use case for some of the recent AI developments is absolutely here, because AI can do a tremendous job of curating the resources available to someone. Hey, if we know that Sachin might be eligible for a copay subsidy, or Sachin might be eligible for using some HSA dollars he doesn't know, we can personalize messaging to Sachin through technology in a way that would be really hard for a staff member in an ED to do, or a billing rep in a call service center. So, Brad, I'll turn it back to you on the next statistic here before I ramble on too much.
Yeah, no, all great points. So another data point here, 75% of healthcare finance leaders, CFOs, stress that greater transparency from payers is essential to strengthening relationships and improving outcomes. This is for Sachin. The payer-provider friction creates consumer friction and frustration, and it often manifests itself as distrust. This tension is escalating, which is obvious from recent news events. What can health plans do to build more trust with providers, but also importantly, build more trust with patients?
Well, I think it starts with actually a much more honest telling of where we actually are as an industry. I think health systems and health plans alike have gaslit themselves into a belief system that is self-reinforcing and frankly gets in the way of us actually making forward progress. Go to any national health plan in the country, name any single one, and read their mission statement. And there are people who believe every word in that mission statement. And, it's some version of we care for the whole person all of the time with all the best this, that, and the next thing. When in fact, what they're doing is utilization management, paying claims, contracting a network, and answering a member service hotline. And occasionally there's a good story that comes out of care management that can make people feel like they're doing something positive for the world. Go to health systems. Health systems are providing life-saving treatments to lots of people, but they're oftentimes putting people into a mound of debt. They're engaged in aggressive billing practices that, create a high degree of financial insecurity for people. We're not going to solve these problems until we actually say what is actually happening. So I think it starts with talking about what's actually happening, with being, approaching this world where patients are frustrated and fed up with a degree of humility that this industry has never seen before, because we're too busy telling ourselves, how great we are and how aggrieved we are by other parties, and start thinking about the little things we can do to make things better for people. And I'll give you a few examples. It starts with, examples like I talked about before, like getting out of the idea that 2 or 3 weeks is a normal time frame to respond to a member's inquiry. I heard about something today that made the hair on my back stand up, which is that a member reached out to us and said, I need a new, member ID card, a problem that could take us 24 hours to resolve. That if you were to call your credit card company tomorrow, we would deliver, that card would be delivered to your doorstep the very next day. That member, 2 weeks after actually threatening violence against, a SCAN health plan staff member, so somebody who we should have taken very, very seriously, 2 weeks later had still not received their member card, because we have normalized very abnormal things in healthcare. And if you pause and you go back to that moment before you actually started in healthcare, and you thought about first principles before you got socialized into the dysfunctional context that you've been socialized into, then you would think it's completely abnormal that 2 weeks was an acceptable time frame for a SCAN health plan member to get a new card. But after working in this industry for a number of years, you're like, yeah, that's just kind of the way things work. And clearly that frontline person, the manager to whom it was escalated, the director, the VP, the senior vice president, the corporate officer who was responsible for that, just kind of had accepted that this was a normal time frame. We have to change ourselves before we can expect others to change. And truly, the industry response to what happened with Brian Thompson was like, oh, we have a dysfunctional industry and we got to make it all better. Bullshit. We are all part of the dysfunction, and there's little things that we do every single day that actually contribute to that dysfunction. So yes, the bigger, we have government relations folks and policy folks that are working every day to try to actually, fix the broader context. We got to continue that. That's track one. But track two is the things we do every single day to actually create frustration for patients that we need to get sorted around. And so that's the work, I think, is for us to look inwards. Health plans have to look inwards. Health plans need to look inwards. And then we need to look inwards together and say, what are we doing? How do we stop the craziness that we've created for people? How do we create an easier system? And I think there's a lot of opportunities for entrepreneurs like Seth and others to build solutions that'll actually address these types of challenges for us.
And Sachin, I gotta just add, sorry, Brad, I'll be really quick, is like your point on looking inwards is you gotta be willing to take the first step, right? Like I talk about that payer, and we had a really wonderful innovation idea, but they insisted on leading with that stupid specialty drug, margin reduction request, right? And it killed the spirit of what we were showing up for. And so it's look, one side has to take that first step and say, look, in the spirit of better patient care, in the spirit of better patient access, I'm gonna propose that we fix this thing on our side. Right. And if you lead with that, you just open the space for people to be like, oh, gosh, they're modeling something here. Maybe I got to think of that, too. Right.
100%.
And look, if there's anyone out there, I'll just make an advertisement. If anyone here is looking for an MA partner that's thinking about things differently, SCAN Health Plan wants to be that partner to your health system or healthcare organization. Because, at the end of the day, this is ultimately about industry culture that we're really talking about. And the fact that we have normalized things that are abnormal. We have engaged in what I call ethical erosion, where we've normalized things that our younger selves, our more innocent selves would find completely unacceptable.
I saw a comment from Billie Jean pop up just a second ago that employers and benefit designers need to be involved in that conversation. Obviously, they're a huge piece of this as well. But to your guys' points, everybody needs to be a part of this. And it does feel like this year should be a very introspective year for this industry. And I love the self-awareness, Sachin, and I like what you guys are saying. I think it's not just, I think it's patient experience, which is the outcry that we're hearing, but I also think it's sustainability, the sustainability of the system. I'm not sure that we can look back in another, whatever it's been, 60 years from Nixon and say, well, now it's 60% of GDP. I don't think we get to that point.
I hope not.
All right, on to the next data point here. 75%, hang on, where are we?
You're on the next one. I think it's
there we go.
Yeah.
It just switched for me. Okay. 63, we're going to talk two workforce points. 63% of CFOs have said that they have increased staff for AR follow-ups, highlighting administrative burden. And then the next point, 75% CFOs have said that they've added more FTEs to manage insurance denials. So this, Seth, is for you. Given these last two workforce data points, how can technology...
I just want to editorialize for a quick second. How is that possible that it's not 100%? I mean, I'm just curious about that.
Fair point. But a heck of a lot of providers have added
maybe because
staff.
they've been recruiting and they can't staff the position yet because it's just taken a long time. So
that might be the answer. Might be the answer.
So how can, Seth, how can technology and innovative payment models help reduce administrative burden and importantly, improve the financial experience for both providers and patients?
Yeah. Well, I think, again, look, I know it's overplayed and everyone's talking about AI, but I think the good news here is that, well, you take a step back, right? Just for a second, right? Labor is about 59% or so of the total cost of a non-for-profit hospital. At HCA or some of the for-profit hospitals, they're closer to like, I think 45%, but for non-for-profits, it's around 55 to 60%, right? So labor is the predominant cost, right? And healthcare is the only industry in our country where we've seen declines in labor productivity over the last few decades, right? So again, I get that why people might feel like if there are cynics out there who are like, oh my gosh, AI this, AI that, like hype cycle, like it's not gonna happen. I would say actually healthcare is a really great place to look because number one, we are the one industry that has seen declining labor productivity. Number two, we are the one industry that is seeing tremendous cost increase of labor as a percent of total cost. And number three, I'd also just point out that healthcare had never really caught some of the last big technology waves, like cloud infrastructure and SaaS, like never really hit healthcare in the way it has other industries, which means we have even more to gain by taking advantage of this current technology. And so the one, if you'll go to the next slide, the one example I'll give here is we've done some research to look at a billing service center for a customer. So it's a large hospital. And we looked at, again, I want to be really clear. This is a billing service center. So what does this service center do? It's meant to collect dollars on bills. But it turns out that 97% of the calls that they were receiving were not to pay a bill. 97% of the calls were to ask a question about the bill. So just think about that for a second. So so many people on this line are probably managing early out vendors or call center servicing vendors, and your whole ROI analysis is all around, okay, I'm going to pay for this service center, and in return, I'm going to get collections of dollars. Well, in this case, 97% are just asking questions. And so when we looked at that further, we found that the number of questions and the variety were they were very homogenous, right? They were asking the same questions all the time. Why do I have this line item denial? Why does it say patient responsibility when my payer said it was provider responsibility? Why does my EOB not match my claim? They were the same questions over and over. And so AI is really an ideal technology for these kinds of use cases. It's not clinical, so the consequences of error are not nearly as severe. They are rote and repetitive, so that means you can fine-tune a model very, very quickly, and you can take out major staff costs here. So, and by the way, back to payer-provider collaboration, we have been actively working with payers. And actually, we have some attendees on this call who've been working with us on this journey for many years. So shout out to Steve Sharman there, who I see on the attendee list. But we have been gathering data from payers for years now to give us information about deductible and benefit information. And the payers want to give us that because guess what? They're getting calls too about bills. So bottom line is you can reduce the staff inefficiencies partly by the adoption of AI, but partly this is a wonderful place to collaborate with a payer because they also are overwhelmed by calls from their members asking, complaining about bills. Hey, now we are back to a quick poll. I feel like this is like a commercial break of sorts. What percentage of calls do you think could be reduced with automation? Give folks a moment to respond. And again, to be clear, we're talking about customer service calls within the revenue cycle world, right? So, your billing service center, customer service center. Give people just a few more seconds. Hey. Well, the answer was 35%. And by the way, that's from where we are today. We expect that to go up. And so just imagine what your call center could accomplish with 30% fewer calls. Imagine how much voluntary attrition you could allow for and not have to sweat at all, because all these call centers see so much attrition and there's so much expensive turnover, right? I mean, for us, this is where we get really excited. And you can also do so much by way of hand-holding patients through tough situations. And so for us, we see this is one of the biggest areas to drive some cost relief for providers, and again, to help allow payers to contribute. And so for us, the way we think about this, just to go a little bit deeper here, there's sort of different levels of this. And back to kind of Sachin's point, right? You got to put yourself in the patient's shoes. There are going to be situations where many patients, they don't want to talk to anyone anyway. That's the other thing, by the way, about healthcare servicing is the good news here is you're not driving people away. No one wants to call into your service center. And so anything we can do to prevent that. So how do we embed intelligence right in a technology workflow? So in our billing app, we'll say, hey, Sachin, we see you have a co-insurance. Your co-insurance could vary by these things. Here are some reasons why your cost estimate might be a little different than what you expected. We'll follow up with you after you get the bill to just confirm where you stand. Giving some information right there in the apps to prevent the need to call altogether. But then the next step is all right, well, let's say you do have a reason to call in. How do we use virtual agents, right, to carry out a conversation without any human intervention? And I'm sure many of you on this call have started listening to some of these AI demos. I don't know, Sachin, if you've had a chance, but these virtual agents, if you're thinking in your head about the IVR workflows of press 1 for, this is a very different world, right? You choose the accent you prefer. If you want someone with a Northeast accent or a Floridian accent or a California accent, you can select the accent and it sounds like you're talking to a human. And then the final piece, though, is let's be real, right? If you're dealing with a cancer diagnosis, or maybe you have that awful authorization delay that Sachin was talking about before, you might really just need to get someone on the phone to hear you out and kind of help you navigate. And in that case, we still think there's a role for AI, where you then equip the staff member with the right information to say, okay, here's kind of the benefit design. Here's what they might have in their HSA account. Here's where they're qualified for financial assistance. Have all that information there so that that rep can work with efficiency and empathy.
I mean, we call this last one, Seth, using AI to turn humans into superhumans.
I love that.
And I think that is, we oftentimes you've got frontline folks who you've got 6 or 8 weeks to train them. And you do the very best you can in that 6 or 8 weeks. And you got great training programs, but you can't prepare them for every single scenario.
That's
right.
And
so if you've got ambient listening, or if you've got tools that enable them to really zero in on exactly the information that they need to provide more support, I think it really makes a huge difference. And that's a bit of what we're doing with our overhaul of our member services, is really trying to drive more and more point of service tools for people so that humans can be more effective in delivering service. We have not gone to AI agents on the kind of member service side, but the idea of using AI tools to equip humans to make them into superhumans is a big part of our corporate culture.
Yeah. And I think you make an important point too, which is like a lot of times, sometimes we talk to folks who think it's like, okay, I'm either going to adopt AI or I'm going to go hire more people. And what I'm hopefully conveying is that it should not be an either or. AI has a role in different ways and different manifestations, right? So there's AI powered chat, there's AI co-pilot assistance, which is sort of what we're talking about right now. There's full virtual agent work. And so highly encourage folks to not think of it as a kind of binary choice, but there's different ways to dip your toe and to kind of test different flavors for this. Right. In fact, a lot of our clients, when we talk to them, we start with a co-pilot model exclusively. So it's entirely about equipping that human to be more superhuman, as Sachin said, and not have it patient facing at all, so that we can show that it's working and that we are maintaining patient safety and all that. And then only after a period of time where we've demonstrated that efficiency via co-pilot, we might turn it patient facing, but it's a staged and kind of evolved thing. Okay. So we're going to get to Q&A very shortly, but in terms of this case for change, it's like, look, payer provider frustration is not new. Payer provider tension is not new. And certainly there's nothing new about the fact that healthcare costs too much in this country. What is new is the fact that patients are now absorbing the costs and the friction in a way they didn't before. And, Sachin made reference to, last month's assassination of the United Healthcare CEO. There's toxicity out there. There's vitriol in social media. There's many reasons for it. I'm not trying to in any way simplify or reduce it, but we are clearly at a moment where consumer frustration is at a boiling point, right? And so if we were to ever argue that it feels like we're getting to an unsustainable moment, it seems like we're getting pretty close to one right now, because the consumer has now been kind of the recipient of a lot of this. And now the consumer, their relationship to you as the provider is far more financial than it ever has been, right? They're seeing that payer provider friction because they're the ones not getting the authorization. They're the ones with the EOB that doesn't match the deductible, right? So this is now a moment where the patient has sort of been dragged into it. And so if there's ever a moment to feel that motivation to reach across the aisle and find a way to collaborate, we hope this is it. And I do think that billing is a place where there's collaboration that exists, because you have resources like HSAs, you have resources like enrollment and coverage, places where both the insurer and the provider want that patient engaged. And because the patient complains both to you and the payer about billing, it's really a wonderful place to kind of say, hey, we got to collaborate here because we have the same goals. So that's my pitch. We're clearly very passionate about it, always happy to talk more about it, but I'll turn it back to Ashley now for Q&A.
Thank you so much, Seth, and Sachin and Brad. This was a really engaging and timely conversation. I would like to invite those listening to enter your questions in the Q&A box located on your computer screens. Earlier, Seth, someone mentioned they had a question about the amount of patients without insurance increasing, or is it just the amount owed by patients without insurance increasing?
I saw that question. It's both, actually. So there's a couple things that are going on, right? We've seen waves of Medicaid redetermination. So different states have been hit with this more than others, right? Where people get rolled off Medicaid and then they don't re-enroll. You've also seen various parts of the country that have been impacted more by unemployment. I think there's certain areas in Pennsylvania, for instance, where we've zoomed in and seen real impact there. When people are unemployed and they get churned off of an ACA or self-insured employer plan, they're not necessarily getting re-enrolled. And even the past couple of days, we've seen some instability with Medicaid, right, which is going to drive kind of both the number of patients who are unenrolled as well as the amount of money they might owe, because medical costs keep going up, and so bill charges are going to go up too. So it's both.
Thank you, Seth. If the industry
can I push on this a little bit? I think some of what needs to happen is I think in that period where people are really out of pocket and they start getting bills for charges, when they don't have access to the pre-negotiated rates from their health plans. I mean, they experience health systems and medical groups as through the lens that most people do. It's just lunacy. Right, the bills that they get are just pure lunacy. I think we need to kind of look at all of that. If people are really out of pocket for that first $4,000, I think we have to be thinking about how we're showing up to people as health systems and medical groups. And as health plans, I think we need to be thinking about, like, is this high deductible thing the right answer? I personally think we should be thinking a little bit more about a lot of first dollar coverage on things that people really need. Because in the absence of that, people are finding themselves really, really exposed, and insurance is providing no assurance to people who frankly need it.
Yeah.
And
so I think there's got to be a lot of product redesign here.
right.
Yeah.
Yeah.
I was just going to quickly add, Sachin and I can go all day on this, and I'll shut up and let Brad go to his next question. But I just add that that's why for us, like if we know that 50% of bill, like, I mean, you're making a point about high deductibles, no dispute about that. Like, but if 50% of your billed AR is coming from folks that don't even have coverage, like that's not a billing issue. And I think for us as a company that really evolved as a billing company, I think it's a lot of people know Cedar is a billing company. Like we're no longer thinking that way because we're realizing, oh my gosh, for maybe 50% of your population, we'll engage them on billing. But for another 50%, before we even talk to them about billing, we have to figure out how we get them coverage. Like it's sort of like preventive financial care. Like you got to do something upstream, and we cannot just send them to the billing department as if like that's just a normal, course of the day. Sorry, Brad.
Fine. I was just going to say that high deductible plans are turning hospitals into collections agencies, right?
Turned, yeah.
Yeah. We can move on to the next question, Ashley.
The next question in the chat is, if the industry stops being promiscuous, would that impair competition within the industry? Don't let everyone speak at one time.
Well, I was going to let Sachin speak.
Seth, go for it. Go for it.
Promiscuity is your comment. You go for it.
Can you repeat the question again, please?
Sure. If the industry stops being promiscuous, would that impair competition within the industry?
Right.
Well, I think the competition would be along the axis of payer-provider partnerships. So, like, just take Southern California, or you've got Kaiser Permanente. It's partnered exclusively with the Permanente Medical Group. Let's say Scan were to partner exclusively with a large medical group. There would be competition, but the competition would be this plan provider entity partner, that's competing with another plan provider entity. And we'd be competing against all the dimensions that we should be competing on: price, quality, performance, experience. Right now, it's just a mess. And there's very little integration, and there's very little collaboration. And you've got a portal for your health system, and you've got a portal for your health plan, and you've got a EOB from your health plan, and you've got a bill from your health system. It's a mess. Again, I talk about normalizing the abnormal. This is the stuff we've normalized. I mean, your health plan EOB is completely inscrutable. Most health systems bills are completely inscrutable to people with the level of health literacy that most Americans actually have. So we've got to do better, and that's the idea that I'm pushing with this idea of longer, deeper partnerships, 10-year, 20-year payer partnerships that look almost like we're operating as one because we have a common financial journey together.
Thank you, Sachin. Is the patient-payer-provider relationship a zero-sum game? If it is, we'll never have collaboration. Dennis says, when someone wins, someone else loses.
Yeah, Dennis, I'd say don't lose hope, buddy. No, it's I don't think it's exclusively zero sum, and I do think that billing is an area where you absolutely can collaborate, because again, as I was saying before, billing is one of the few places where providers feel it because people call in to you when they're confused, but members also call their health plan when they're confused. In fact, it's one of the biggest reasons for billing and dissatisfaction, billing call volume and dissatisfaction. So it is a place of common interest. And that's why we have seen payers work with us, giving us benefit information, giving us deductible information, giving us HSA dollar information, and we are loading it into provider bill pay workflows because they see there's value in making sure that their members aren't upset about bills, right? And also back to the point on self-insured employers, guess what HR people at employers are dealing with all the time? Some employee has had a problem with a bill, and that HR manager needs to get on the phone with Cigna or Blue Cross and try to work out what's going on. So they also get it. So this is one of those few places where you actually have the employer, provider, and payer aligned. And I really encourage like this being a place to focus and consider some collaboration.
Thanks, Seth. Rose would like to know that with the current debt forgiveness regulations, do we anticipate any patients to pay their medical bills?
I understand the point. Obviously, I do think patients will. Here's actually, no, I'll make a more serious point. We have done extensive research on the question of affordability and willingness to pay, right? That's our business. Like, that's how we were built. We have thousands of consumer test panels we run, and I'd be very happy with anyone who's interested to learn. If they want to learn more about our primary research work, I'd love to share. Here's the reality, and Sachin, you can, validate or pressure test this, is that people, when you ask them about their care, they are consistently thrilled and grateful for the care that they receive. Like, when they leave a care event, they will talk glowingly about the quality of the nursing staff and the physician staff and how grateful they are. And they absolutely want to, like, take care of whatever obligation they owe to these people. That is the consistent sentiment. And more often than not all the time, but more often than not, it's not a willingness to pay, but it's affordability barriers. Gosh, this is bigger than I expected. I wish I knew how to spread this out over time, or I wish I knew if there were resources to help me, or I wish I knew if I could get a discount if I pay a bit upfront now, or I'm on a payment plan, but I'm having a tough month. I wish I knew I could pause it. Like, these are the barriers. Or my EOB doesn't match what my bill says. I wonder if my insurance and provider are reprocessing this a number of times. I'm just going to wait and not touch it. These are the things that we hear consistently. So I actually am optimistic, and frankly, we are seeing continued performance with our clients, even with this legislation, because I do think people actually are grateful and they want to express that gratitude. They don't want to stiff their providers.
Thank you, Seth.
And what I want to say to whoever asked the question is, I want to ask you how we got here, how we got to a place where we're talking about, either forgiving or not, damaging people's credit ratings because of their healthcare bills. We got here because some of the practices of provider groups were a little bit insane. Repossessing people's homes, not-for-profit health systems repossessing people's homes because they didn't pay medical bills. So there's health systems that partnered with large consulting firms that Seth and I have both worked at, that pull together playbooks that seem like good business, but if you're a not-for-profit, really, are pretty bad reputationally. And so again, I think that there's some self-reflection that we have to do on how we show up and how the business that we're in is not like other businesses. When, life or death is at stake, there are slightly different rules to the game. Not all of the rules are different, but there are slightly different rules of the game. And, some of the things that so-called not-for-profit health systems and health plans and for-profit healthcare organizations have done have put us in a predicament where the trust in this industry is lower than it's ever been before. We own that. And we're now the beneficiaries of a legacy of everyone who came before us. And we have to actually change that.
Thank you, Sachin. Earlier, you referred to the relationship with Kaiser Permanente. Like, how would this look in a smaller market?
It's a great question. I don't know that it actually works in fact, in some smaller markets, it is how things work. There's a payer, there's a single payer, there's a single provider, and they work together in lockstep all the time. But in markets where there is some competition, it does look like, kind of integrated health plan and provider organizations that are, working together. You call them, some people have called them our mutual friend, Bob Kocher, coined the term payvider. You can be a payvider through ownership structure. You can be a health system that has a health plan, or you can be a health system that's partnered with a health plan in a deep, long-term strategic partnership that enables you to show up to the consumer as a semi-integrated unit where 1 + 1 really looks like 3. That's what I'm kind of pitching here.
Thank you. Let's see, who else do we have? Okay, so Brittany says, I always feel like I know what questions to ask and what to look for because of the industry, but for the average person who doesn't work in healthcare, how can they learn other than on social media, which is clearly uninformed? This feels like an overwhelming obstacle.
So I have I have a strong, well, look, I'm going to speak to my little corner of the world in this, right? There's a lot to know about healthcare, and maybe Sachin has bigger, grander ideas or solutions. But with respect to billing, I don't think that educating the average consumer about all the things, and I'm not saying that this is what this person's suggesting. I'm just saying, like, I don't believe that we need to burden consumers more with just the foundational education. What I believe, and this is where the promise of AI really comes in, is like, we need to serve up information to that patient that is relevant to them in the moment they're getting it. I mean, if you think about it, and now I'm going to be careful not to go on my soapbox, but like, it is sort of insane how we communicate healthcare information. Like, we have this thing called open enrollment, which is this very odd construct in our world where we decide arbitrarily that some period of time between October and November is when we're going to communicate a bunch of information to patients. And that window of time is totally irrelevant to whatever that consumer might actually be needing in healthcare. Right. And so, like, already we have this kind of history of sharing information and educating in a way that's totally disconnected from need. But with like AI and like, again, the work we're trying to do is saying, okay, we know you're showing up to Dr. Jain for a particular care event, and you have this type of insurance plan, and you have this sort of income eligibility. How do we, in that moment, say, okay, you're eligible for this. Let's connect you to that. Or you're eligible for this subsidy. Or, hey, we see that you could be enrolled in an ACA plan and you could pay nothing because you qualify for a subsidy. Doing it just in time, I think, is the way to do it. And for me, like, these things sound like fantasy ideas now. Like, with the technology we have and the data connection, we absolutely are doing this today, and we can.
Yeah, and on this, on Seth's last point about like having the technology do it right now, we put a man on the moon, I don't know how many decades ago. This is not putting a man on the moon. It is 2025. We still use fax machines. It's time to make those investments to actually, create the kind of more seamless experience that I think, the people we serve actually deserve.
Absolutely. Do either of you have any closing remarks?
Thank you all for joining us for this session. Just appreciate it.
Thank you. And clearly, in case it's not obvious, I have a lot of passion around this topic, and I feel like I've been in the trenches battling this out with many of you. And so if you ever want to have a follow-up, even just to discuss these themes and some class independent of Cedar, connected to Cedar, I'd be delighted. So,
and if you want a progressive Medicare Advantage partner, you can call us. An advertisement for both of us. So thank you.
Yeah. And death to the fax machine.
Exactly.
Thank you all. And with that, we have reached the conclusion of today's webinar. I would like to thank all of our speakers and Cedar for sponsoring this. We hope you have found the presentation informative. Thank you for your participation and have a great day.